Hi, my name is Dr. Raj Ayyagari. I'm an interventional radiologist here at Yale New Haven Hospital and at the Yale School of Medicine. I'm a physician that performs a procedure called prostatic artery embolization, or PAE for short. It's used to treat benign prostatic hyperplasia, which is a problem that most men as they get older encounter as their prostate gland just enlarges and causes problems with urinary flow. The typical way to treat this condition is with medications that help kind of open up the bladder and the prostate. For patients who don't tolerate or don't have a good result with medications, classically they'll go to see a urologist and then end up having what we call transurethral resection of the prostate, or a transurethral enucleation of the prostate, which they'll do either with a laser or an electrocautery device. Those procedures are somewhat invasive. They involve a metal scope going up the urethra. They're done under general anesthesia. They work well. They are the gold standard for a surgical therapy for benign prostatic hyperplasia, but such procedures do have their side effects and risks, and lots of patients who have very large glands end up not being good candidates for the procedure, for the surgery that the urologists do. So those patients can come to see us and we can do this procedure called prostatic artery embolization. It's a very minimally invasive, very low risk outpatient procedure where we'll put a small catheter in about the size of this wire on this mouse into the artery, either in the left wrist, or we'll go through one of the groin arteries. We do it all under mild sedation medication, so patients don't need anesthesia. There's very little pain with the procedure at all. Once we're in the patient's body, we inject dye to map out the blood vessels. We then steer our little catheters into the arteries that feed the prostate, and we inject these tiny little plastic microscopic beads which cut off the blood flow to the gland. We then take everything out, put a little bandage on, the patient goes home the same day. The recovery time is very short, and over time what happens is when you cut off the blood flow to the gland, it shrinks and shrivels up, kind of like going from a grape to a raisin. And what that does is that opens up the center of the gland and kind of softens it and allows the urine to flow much better. Patients usually get improvement. They start to notice improvement 2 to 4 weeks after, and usually the improvement gets better and better and better over about 3 to 4 months. About 9 out of 10 patients will have a really good result, with results almost equivalent to what they get from the TURP surgery, with much less invasiveness and far fewer risks and a much faster recovery time. Patients love it. It works really, really well. And like I said, it's a very low risk, minimally invasive procedure that still has very good results. Right now, the procedure is still technically experimental, or we do it off-label in terms of FDA kind of approval, because it's only been around in common practice for about 6 years or so. Here at Yale, we've been doing it for over 4 years now, and we have by far the largest number of patients in the Northeast. So we've done quite a few of these. We think it works really, really well, and patients have had great results. One thing I always say, nothing beats when you see a patient come in a month after the procedure with a grin on his face, telling you how much happier he is and how much better his life is with his ability to urinate again. So it's a great procedure.